Ok, boa noite, pessoal. Estamos começando o nosso webinar de agosto da Brascrs. Boa noite a todos que estão aqui. Atrasamos um pouquinho por questões de ordem técnica e já vamos começar o nosso webinar internacional de agosto. Nosso webinar de hoje é sobre topografia suspeita no screening da cirurgia refrativa, como identificar, interpretar e conduzir os casos. A gente tem aqui hoje a doutora Bianca Suzana. A Bianca, ela é especialista em córnea e cirurgia refrativa pelo BOSS, doutoranda da USP e Research Fellow no Coley Institute na Cleveland Clinic. O mentor dela, Dr. J. Bradley Randleman, está aqui conosco. Eu agradeço a presença da Bianca. Daqui a pouquinho ela troca uma palavrinha com a gente, né, Bianca? O nosso webinar hoje será em inglês. E então eu vou introduzir o Dr. Randleman. It's a great honor to introduce Dr. J. Bradley Randleman, a world-renowned leader in refractive surgery. He served as director of the cornea service at both Emory and USC, and currently leads the Journal of Refractive Surgery as editor-in-chief. Dr. Randleman has authored over 200 peer-reviewed papers, 50 books, chapters, and 5 textbooks. He has received multiple prestigious awards, including the Binkhorst, Kritzinger, and Founders Awards. He is also a recipient of the Senior Achievement Award from the AAO and the inaugural ISRS Recognition Award. He's professor of ophthalmology at Cleveland Clinic's Coley Institute and editor-in-chief of the Journal of Refractive Surgery. Please join me in welcoming Dr. Randall. Thank you, Dr. Randall.
Thank you very much.
So, everyone, thank you, Fabricio, so much for your presentation. It's a great honor to be here talking to everyone, especially in Brascrs, which is a very respectful entity in Brazil, and I'm really, really happy to be here. Even more happy to be with Bradley here, who is my mentor, and I've been working with him for 1 year with great honor and pleasure. Today, we're going to talk a little bit of topography, show some cases. We try to do something dynamic, so we are going to show some cases, open for a poll, and then you can vote. After doing the poll, Dr. Randleman is going to give a show on everything he has been working for a while now, and it's going to be an amazing lecture, I'm sure. So can I start the presentation? Can I start the cases? I think so. So let's see. And you see my presentation?
Yes, it's okay.
Okay, perfect. So first case is a 24-year-old male patient, minus 2.5 mile. With this topography, you can also see the normal Billing-Ambroso display. And my first question to you guys is, would you do this surgery? Pode colocar a enquete pra gente. So the poll is, you can see in the Brascrs website, and you can vote there for us. So our next case is a 25-year-old female patient, minus 1.75 mile. This is her topography, also showing a normal Billing-Ambroso display. The poll is going to show for you, also in the other website. Please vote whether you would do surgery, and if you do it, which type of surgery would you do? And you have 5 seconds. Okay, let's go to the third case now. And the third case, a 36-year-old patient, minus 2.5 mile, he has a cylinder as well. This is his topography. Everything seems normal, and I want to know if you would do surgery in this patient, which type of surgery would you do it? Please vote, and you have 10 seconds. Nice. Perfect. And we are going to go to the last case now. This patient is an older patient, 38 years old, also myope, low astigmatism, little bit of asymmetry inferiorly, normal billing ambrosial display. Pode colocar enquete pra gente, por favor. Please vote in the poll whether you would do surgery or not in this patient, and also which type of surgery would you do. We have 10 seconds. Patient, and also which type of surgery would you do? We have 10 Perfect. Seconds. So all these results we're going to reassess after Dr. Randleman's lecture, which is going to start now. So I'm going to stop my presentation. And Dr. Randleman can share his own.
Are my slides there? Are you able to see my
Yes.
slide? Okay, perfect.
Yes.
Thank you. Thank you so much for inviting me to speak. And I wish we were able to do this in person. I will be visiting in December. So hopefully we can see anyone and everyone who can make it. Talking about suspicious topography. And in order to talk about suspicious topography, we have to unwrap some of the things right now. And then I'm going to show you a little bit of our lab's research that I think is going to help guide some of our ideas moving forward. I don't have any formal disclosures, but we are supported by 2 R01 grants from the NIH, both related to Brionne microscopy. So the question we try to ask in clinical evaluations, which one of these patients, if either of them are a keratoconus suspect? Both of these patients had similar maps in both eyes, both corrected to 20/20 or better. So how do we differentiate these types of patients? And the current standard right now is multimodal imaging. And this is all imaging that we have at Coli. We do Placido imaging, we do anterior segment OCT, we do Scheinflug analysis, and we have the Corvus as well. So that's the sort of the way that that everybody has been attacking this problem, because what we theorize is that the first change is a mechanical change in the cornea, and it has been difficult to evaluate or measure that to date. Now, the current thinking in general is that the early morphologic changes are changes that can potentially be seen, but that would precede anterior curvature changes that we know exist in keratoconus. And so one of these is epithelial remodeling. And again, this is from the literature, that the concept that epithelial remodeling may partially or totally mask the presence of an early cone. The other side of the cornea, posterior elevation changes have been promoted to be the first indicator of ectatic change in eyes with completely normal anterior curvature. And so we look at, and there are now numerous papers in the literature looking at some variety of multimodal imaging. This one was published in JRS a couple of years ago, where they looked at Scheinflug imaging and OCT and biomechanical data, and they also looked at artificial intelligence. And none of those metrics performed particularly well at identifying the subclinical eye. So we've struggled to do that, and more artificial intelligence processes are ongoing, but they've all been a little limited to date. And so it may be time to reevaluate the standard. The first question is, what is normal topography? You will see that term frequently, that is the population being evaluated. One concern I have as a reader and also as an editor is frequently papers will be submitted without any actual topographies. They'll give you values or indices, but no images. So if we were in person, I'd be able to see everyone. And my guess is that, at least for some, that looks like a fairly normal topography. But the question is, which scale are you using when you're evaluating this curvature map? This is the same exact map shown in a variety of different available curvature patterns. And I would argue that the two maps on the screen look remarkably different from one another. And while maybe if you weren't looking at the numbers, you could consider one of those to be normal, I don't think that in the half diopter curvature, the fixed scale, anyone would be saying that is a normal curvature. The Kisa index has been around since 1999 and has been used in different times. And you will see this reported numerous times in papers. Yaron Rabinowitz set that up specifically designed to identify early stage keratoconus. So his primary concern was identifying early keratoconus with a score of 100 or greater. He used a different control group to identify normal as less than 60, and then even though no eyes fell in the middle 60 to 100, they called that suspects. So you'll frequently see Kisa index less than 60 listed as normal topography. We evaluated this last year in some ways in a silly cohort. We looked at patients who had clearly identifiable and identified keratoconus who had documented progression and were going on to cross-linking. So not subtle, not difficult to identify cones. And in this population, 20% of the patients with progressive keratoconus had a Kisa score less than 60, so were identified as Kisa normal. And 5% of that population had what would be considered very asymmetric ectasia with normal topography. And you can see the values right there, as well as the curvature maps and all of the indices. And so again, these were not subtle eyes. Kisa did not perform well in terms of sensitivity. In looking at the literature after that initial paper, Kisa has never particularly performed well at sensitivity. So it's not very sensitive in identifying keratoconus. And even with Rabinowitz later on, 10 years later, showed that it wasn't particularly effective. It's important to look at the 0 to 60 group because that's how people are using the Kisa index predominantly today. And in that in the population, numerous eyes had patterns that we would consider to be abnormal today. Even these are published topographies from that group. So these are eyes that were considered normal in that study. Now, Yaron did speak to these being likely keratoconus suspects, even though these patterns were in the quote unquote normal individuals at the time. So Kisa really from its outset has not been able to identify these types of patterns consistently as being abnormal. The global consensus on keratoconus came out about a decade ago, long paper with numerous values and numerous recommendations in it. One of those, however, was quite specific, saying that posterior corneal elevation abnormalities must be present to diagnose subclinical keratoconus. And we evaluated that statement looking at the literature this past year with really a great group of individuals. And we looked at over 1,200 records from the outset of this and ultimately looked through more than 200 in great detail. We found 29 studies that identified some cohort that could be considered subclinical and that looked at the posterior surface in some way and another surface for comparative analysis. And so when we looked at what metrics were best in each study, we did not compare it between studies because the criteria were just too different. But anterior metrics and thickness metrics predominated as the best metric to identify the subclinical cohort within each study. And only 13% of the papers in the literature showed any success for the posterior metrics. And more importantly, I think, or at least equally importantly, there has never been a time point where the literature supported the posterior surface as being the primary surface of change. We also identified a number of papers that we could not use in our direct evaluation because they only evaluated the D-score. In that population, so these papers sort of seemingly moved on past all anterior metrics, all thickness metrics, and even individual posterior metrics. And first of all, you can see that they didn't perform particularly well at identifying the populations, but they also, many of these used the KISA index for their evaluation as the subclinical group. This is a paper by Shagari and colleagues where they followed suspects over time. And so this is an individual from their study and from the paper in JCRS. Sorry, JRS. Didn't even get my own journal right. Sorry about that. Where at initial presentation, this individual has notable inferior steepening on the anterior curvature map. 1 year later, that steepening is more pronounced, and the asymmetry indices looking at anterior surface are now lighting up as abnormal. And only at the 3-year mark did the enhanced ectasia or posterior surface metrics show up as abnormal. This is another study from 2018, also in JRS, that evaluated this VAENT type of population. And again, they only looked at the BAD-D metric from the Scheinpflug and CBI and TBI from the Corvus. Now, first, none of those performed particularly well at group differentiation. But more importantly for our talk today, if you look at the eyes that were considered to have normal topography, these are simply not normal. These should not be considered normal. These have a pronounced focal steepening that is quite analogous, just not as far along the path of progression as the other eye documented with keratoconus. So these are the types of topographies that can be considered normal by the VAENT system. So if we flip to the other side of the cornea again and say, well, what about the epithelium? And again, it has been promoted to be able to partially or totally mask the presence of irregular stromal surface, including a cone. So we looked at this in an asymmetric keratoconus population. And the short answer is there were no differences between the control group and subclinical group. And only once you had clear demonstrable keratoconus were there any differences in any epithelial thickness patterns. There were no differences at any individual location in the cornea. And when you looked at all of the different metrics available, none of those performed well at differentiating the populations. And importantly, the Scheinpflug analysis, multiple parameters outperformed any of the epithelial metrics in that study. Again, looking at the literature in this, when eyes have had less than clear anterior curvature findings, the epithelium has not performed well in any study to date. Only when there are clear demonstrable curvature changes has the epithelium performed well. Now, people may say that they have seen irregular epithelial maps, and which one of these you would consider to be a clear example of epithelial remodeling in the face of a subclinical keratoconus eye. Again, if we were in person together, I would hope that someone would say that one looks irregular, and it is irregular, but that's not a subclinical eye. That is a clear cone that is easily identifiable with the tangential curvature map. And you can see that the relative difference in curvature far exceeds the relative difference in epithelial thinning in that location. So many of the things that individuals are looking at first and foremost, be it the posterior surface or epithelial maps, and considering those to be the most sensitive are really letting us down. And I think it's important to go back to first principles and understand why that may be. So early studies looked at a bulk reduction in modulus in cones, and that was fairly straightforward and what you would anticipate. Many of the studies, though, with histopathologic analysis, you have to consider are very late changes. B.J. Dupes did a great study in 2011 looking at finite element modeling, and they took an asymmetric cone eye, and they were able to create a focal cone simply by changing the local stiffening or elastic modulus without any change in corneal thinning. You were able, by just reducing the local mechanics, and they had about a 5 millimeter area that they changed in this modeling simulation, they were able to induce the phenotype of a cone in terms of curvature change without any thinning of the cornea. So the concept that the cornea thins predominantly before changing its curvature is not borne out by finite element modeling. Cindy Roberts and BJ had a great theory paper that I would highly recommend anyone interested in this topic, which you are if you're signing on tonight, to look at this paper, because they really lay out the theory quite clearly. And in their theory, it's a focal reduction of elastic modulus that starts this cycle of stress redistribution with ultimately curvature change or deformation and focal thinning. And the focality of this is important because you need to induce an asymmetry in properties. So if you have a local region that is weaker than the surrounding tissue, that region will strain to a greater extent because it has higher stress than the tissue surrounding it. If you have a global change, you will be much slower to develop anything that we consider to look like a cone. Why does the cone develop in keratoconus? So if we look at corneal collagen microstructure, and this work is really from Jamie Jester's group and just fabulous work with second generation harmonic imaging, you can see that there are real differences based on depth in the collagen structure. The posterior stroma has parallel fibers that are thicker than the anterior stroma. There's really no or minimal, at least, interweaving of those fibers. They run limbus to limbus. When you get into the anterior stroma, you have a much more isotropic organization of these fibers, significant interweaving. And then in the anterior 100 microns, you have this real dense nesting, if you will, of these fibers where there's tremendous interweaving. There are numerous fibers that connect the anterior stromal fibers to Bowman's. And this is really where most of the stability in the cornea lies. Now, what happens in the keratoconic cornea, also by Jester's group? The posterior stroma has no disruption of the fibers, but undulation because they're not under as much stress and strain. The anterior section of the cornea, though, has changed dramatically. You have loss of this interweaving of the anterior stroma. You have loss, or at least reduction, in the number of transverse fibers. But interestingly, this phenomenon only occurs centrally. In the peripheral cornea, even in more advanced cones, there are still interweaving and bridging fibers present. So it's really a central phenomenon. So if we say that we're looking for mechanical changes, we know that it should be somewhere in the general central region of the cornea that are most likely to have those changes. BJ's group, again, looking with optical coherence elastography from a few years ago. So this is now in vivo work, but looking at patients with known keratoconus versus normal populations. They found a significant difference in the stiffness of the cornea between the anterior cornea and the posterior cornea in a normal population. In the patients with early keratoconus, they found a reduction of the anterior stroma only. So the posterior metric, or the posterior values, were no different between cones and normal corneas. The anterior values, though, were significantly reduced. So they hypothesized that this is an anterior stromal phenomenon. And that brings us to some of our lab research using Brillouin microscopy. I won't go into great detail about the background of it, but we do have a paper recently out in Survey of Ophthalmology that really goes through some of the anatomy that I just talked about in greater detail, and also the function of the Brillouin microscope in greater detail. As a very brief overview, we are looking at the Brillouin scattered light, which induces, so the interaction between the light coming into the, in our case, in the cornea, that light interacts with a local phonon, and the phonon is generated by the local tissue properties. And so stiffer tissue will reflect light and cause a different frequency shift than softer, less dense tissue. That can be measured, and then the Brillouin shift can be reported. In looking at the data that Brillouin has generated over time, you can see when you look at destructive ex vivo analysis of tissue, there is a depth-dependent curve in the cornea in terms of tensile strength or stiffness, and that same curve was generated with the first papers looking at ex vivo with Brillouin microscopy. Now, Brillouin microscopy, and this is all with my collaborator Giuliano Scarcelli in his lab. It was the first to look, and again, this is ex vivo here. The analysis of the Brillouin shift, or the stiffness of the cornea, as you would expect, was significantly lower in the keratoconic population in these corneas, but only in the cone region. Outside of the cone, there were no differences in corneal stiffness. So this was really the first paper to show a focal change in corneal properties. This was the first in vivo work with keratoconus, and the same thing. So you can see these were more advanced cones, but in the normal population, there was a fairly even distribution of mechanics across the cornea, whereas in these advanced cones, there was a focal area that was significantly softer, whereas the periphery stayed the same and was not significantly different than the mechanical properties in the normal corneas. So now, there's been some earlier work with a prototype device. That's not what we've worked with in our lab. In our lab, we've used a motion tracking device that has an eye tracker, but also importantly has an OCT, so we know where we are in depth. And so we're able to create this same type of depth-dependent map that has been done in the past ex vivo. And then so we have taken that information from the anterior portion of the cornea and converted that into a regional stiffness map. The first population we looked at in 2023 were patients, either normal or known early keratoconus patients, or patients with stable laser vision correction. So again, easy to identify these groups based on their curvature maps. When we look at their Brillouin maps, you can see that there's a significant difference. In the normal cornea, there's greater stiffness across the cornea, and it is highly uniform across the cornea. Lower values in the laser vision correction group, and real focal weakening in the keratoconic group. Now, again, these are not suspects. These are patients with diagnosed keratoconus. Most of these were going on to have cross-linking. So the Brillouin shift was able to separate these populations, but these groups could be separated anyway with morphologic imaging. The next study we did was looking at keratoconus suspects, or subclinical keratoconus eyes, and these were really subtle eyes. These are examples from the paper, but these were early eyes, and again, you could see pronounced changes in the Brillouin shift maps. And in this population, all of the different Brugman metrics that we looked at were able to differentiate these populations. And the mechanical data from Brugman imaging was much more effective than any of the Scheinpflug analyses. And again, this is the entire cohort shown here. And I think this image really does a nice job of expressing just how different these eyes look mechanically as compared to the overlap they had morphologically. So I think we're fairly comfortable today saying that mechanical changes precede morphologic changes, which I don't think surprises anybody. I think most people would agree that that sort of makes sense. It follows theory and it follows what we've seen to date in the literature. The two newest studies I'm going to show briefly go into greater detail, though, and these are really the reasons why we should be looking at anterior curvature, particularly focal or asymmetric curvature changes in our clinical imaging. So in a three-dimensional analysis, and again, I've got the codes. I encourage anybody interested to look at the actual papers. But in this, we looked at this just slightly differently. The anterior portion of the cornea, in every different way we've been able to look at this, is significantly stiffer than the middle and posterior portions of the cornea. In this study, we simply divided the cornea into thirds and analyzed the Brugman shift by region. And when we looked at the subclinical eyes and the normal eyes, the anterior minimum values were able to fully differentiate the eyes, and all anterior values outperformed the middle values, which outperformed the posterior values. And the posterior mechanical metrics performed worst and were least sensitive at being able to differentiate these groups. The difference in each eye between the minimum value and the mean value was more pronounced in the deeper layers. And then this image, I hope, conveys this as well as anything else. So if you look at the anterior stroma, the control eyes, the subclinical eyes, and the early cones, there are clear focal changes in stiffness in the subclinical eyes and the cones, and very little difference across the normal control cornea. As you go into middle and posterior layers, there's more variability across the normal cornea and less of a focal pronounced change in the subclinical or manifest keratoconus eyes. And if you look at the posterior stroma, it's really difficult to determine which eye goes with which group. So the changes in the keratoconic eyes were much more pronounced in the anterior portion of the cornea. So now we can change our focus a little bit, and we say, well, okay, so now it's really the anterior portion of the cornea that institutes the first changes. A paper that's just available as of this week in Ophthalmology Science, looking at the proximity between the thinnest corneal point and the point of focal weakening. And so again, these were with two different devices. We identified the thinnest corneal point using an OCT device, and then the softest corneal point using Brugman imaging. And these are from the anterior plateau region, as we've shown is the most important. When you look at where these values localize, they really localize in the same region for the most part in all of the groups: control eyes, subclinical eyes, and early keratoconus. And when you take all of the eyes and you center the values on the thinnest corneal point, you can see that the vast majority of minimum values are within a millimeter of the thinnest point. So now we really know where to look, and we also have some ideas, at least theories, on why that is the case. A paper from last year by Cindy Roberts and her group found that the point of maximum stress in the normal cornea co-localizes very tightly with the thinnest corneal point. So now we are seeing evidence that the point that is thinnest on the cornea also has the highest stress and has the weakest point of the cornea in subclinical disease. So now we really know where to look in that population in terms of where you are going to see localized mechanical changes first. So if we go back to these eyes that I showed at the beginning, both with mild inferior steepening, one cornea is thicker than the other, no other real pronounced changes morphologically, the mechanical maps are remarkably different. There is a significant softening in that in that suspect eye. Looking at this type of patient with some mild asymmetry in the curvature, but really normal values in terms of global mechanical changes, because that's what the Corvus is able to tell. Normal CBI, normal TBI, normal PRFI, normal BAD-D in both of these eyes. But again, pronounced local mechanical changes. Now, again, outside of that area, you can see that the values are much higher and much closer to normal. So this really is a focal disease process. All of this work has happened because of my wonderful group. Bianca has been an integral portion of that. And even though she's traveling south, she's going to remain an integral portion of that. And so, again, I think that helps guide us on where to look and why we should look in the anterior portion of the cornea. And so I'll turn it back over to Bianca to show the outcome of the patients we had.
Amazing, amazing talk. Thank you so much, Brad. And I'm always amazed about not just the talk, but all the pictures you just share with us. They
Thanks.
are beautiful. So I have a lot of questions here already, but I want to first present the cases again. We can discuss the cases, and then I can ask the questions for you. So let's go back to the cases. Okay. So this time I'm going to give you more time to look carefully to case one. This is a low myope patient, 24 years old. And I'm going to ask you again, you can definitely do your vote in the poll. Então, pode mostrar pra gente a enquete, por favor. Please vote whether after the lecture would you do surgery in this patient. I'll give you some time so you can see the topography and the pachymetry. I'll give like 20 seconds. People were mad at me because I was going too fast the first time. So I'm going to give you 20 seconds. And
It won't
just
help.
so
20
just
seconds
so
won't help. It's okay.
okay. Okay. So just so you know, the first time the majority of people said no surgery.
No surgery.
No surgery, exactly, which makes me happy. So I'll let you comment on this, Brad.
Well, so what we did in these maps was give you the anterior curvature in scales that are not particularly sensitive, but that frequently show up in patient examinations or the literature. So when you go from this relative scale, where again, all the numbers are there, but it's hard to see much. If you then go to a fixed scale, so this is an axial curvature, now you can see focal steepening, particularly in that right eye. And if you go to tangential curvature, which I really didn't talk about today, but it does a much better job of localizing a cone, you can really see a focal area in that right eye. And now my guess is that this eye had an abnormal D score as well, or a mildly suspicious one. And I'm guessing that may have been part of the reason that nobody operated.
Yeah. This time, some people decided to operate, maybe because more people voted than the first time. So it's good that we made it clear that we have to actually look slowly at numbers, look at the scale, and then make sure we are also judging the tangential map. So this case too, the majority of people decided to do LASIK in the first poll, and I'm opening here the second time this poll. Please, everyone vote. Pode deixar a pesquisa aberta para mim nesse caso. So first time, the majority of people 60% decided to do LASIK. And now I'm gonna close the poll. Vou fechar a pesquisa. And now only 30% are doing LASIK in this
Nobody's
patient.
gonna operate post-operatively now. Everybody's nervous, but
Yeah, but actually people change for PRK. So actually this patient, we did the same thing here. You can see the axial curvature in the relative scale. But if we change for fixed scale, you can see that it's easily to note the ectasia post-LASIK.
and these are the preoperative maps. I think it bears and then if you click to the tangential curvature, you'll see really how focal that is. If you could go through that one more time, Bianca, I just, to me, the fact that you can set your device to be what many people would consider to be a sensitive-ish scale, a half diopter relative, and you get no curvature information. So this is another person who developed ectasia after LASIK, and if you go back to the four-map view, there's really nothing that jumps out in thickness, anterior curvature, thickness, anterior elevation or posterior curvature, or any of the enhanced metrics. Now, looking back on this and knowing that this patient developed ectasia in the right eye, you can see some changes in anterior elevation. But really the primary driver in terms of your evaluation is if you had your curvature map set with sufficient sensitivity, and particularly if you use the tangential map as well, then the information really jumps out at you.
Perfect. Third case was the case of a 36-year-old male patient, low prescription, older patient. 70% of the participant decided to do PRK in this patient. And here you can see that again, everything seems normal, including the elevation and Williams-Browser display. But this patient developed ectasia, and this is the absolute scale. So again, if we change the scale, we can definitely see there were some focal changes and this pattern that reminds of pellucid pattern, right?
And that's the key, is that you lose all of that data when you have that, even in that absolute scale, because the absolute scale is challenging because the numbers that we really want to look at are, for the most part, masked in terms of color-coded analysis. And if you didn't think that the color coding was important before this, I hope that you feel that it is afterwards. We are pattern recognition animals, and it's much easier for us to see patterns than it is for us to look at the numbers and do the math. And then again, if you look at the tangential curvature here, it really jumps out as that focal steepening that's inferior in both eyes.
Perfect. And here's the tangential map.
Yep.
And then finally, the last case, which some people notice actually that there is an inferior steepening besides all other maps being normal, but 50% decided to do PRK in this patient. And again, with this scale, everything seems misleading, but if you change for the fixed scale with 0.5 diopters, and if you try to see the tangential curvature, all these changes, they are more evident and easier to notice.
And one of the issues that is true, curvature is highly sensitive for changes. It is not as specific as we wish it was. And so this is a case where the folks who do default to anterior curvature get fairly nervous and or would not operate typically on this individual. But in this individual, we were able to get regional mechanical maps and found that they were completely normal. And so this person had PRK and did very well.
Amazing. So I'm very, very excited to see more of this project on Reload. Really, I know all the ideas you have. I'm so excited with the future. Um, I have a lot of questions. I think we still have around 5 minutes because 5 to 10 minutes because we start late, but let's not take too long from Dr. Randleman. Uh, First question that I have for you that they are sending me here is if first, whenever you find someone with a suspicious topography, but not definitive keratoconus, how long do you follow them? For how long do you consider this is safe enough to consider they are stable and they could have like any kind of refractive surgery?
So that's and what I will say up front is I don't think that there's great data to support any specific decision here. I first thought you were going to ask how long you needed to follow them to determine if they were going to progress and need to be followed closely or not. If I see a patient under the age of 25 and I feel that there are real concerns in terms of the cornea morphology, potentially corneal mechanical issues, I'll generally see that person again in 3 months, and particularly under the age of 20, the rate of keratoconus progression in that age is dramatic and can be fast. So I usually see them in 3 months. If nothing changes, I'll see them in 6 months. If nothing changes again, I'll see them in a year, but not in terms of evaluating them for surgery. That is to evaluate whether or not they seem to be progressing in the keratoconus spectrum on their own. Once you have an atypical imaging process, even if that cornea stabilizes at that level, that does not mean that it is stable and able to withstand surgery, because you are going to do something dramatic to that cornea depending on what surgery you do. I do think that if you're going to consider any surgery in atypical corneas, PRK is definitely the way to go. I would take LASIK off of the table. I would also take SMILE off of the table. And again, BJ has a couple of really good theoretical papers on that. If you think of the anatomy that we just looked at, and if they are having abnormal or asymmetric curvature, the likelihood is their cornea anatomy is different in the anteriormost portion of the cornea. So if you do SMILE and you leave the abnormal, less strong anterior cornea, and you take out the middle layers that may not be as involved mechanically yet, you're probably doing a worse thing than not operating or doing PRK, where you're ablating some of the tissue that's already not doing its full job load bearing. But if I'm not happy with the curvature or the overall morphology of the cornea at the first visit, I'm unlikely to operate unless I say only had morphology at the first time and I get mechanical data later on. I think the concept that it's irregular but it has remained stable is not something that I tend to use from a clinical perspective. Now, I do all of that in terms of age. I tolerate more asymmetry in 40 or 45-year-olds than I will in 20 or 25-year-olds, but I don't have specific numbers for any of those.
Yeah. And talking about age, do you consider the epithelial mapping differently for age? For instance, patients, epithelial mapping, do you put any consideration regarding age?
I will tell you that we use epithelial mapping routinely. I think there's a lot of great information the OCT gives us, and we don't even look at a lot of or talk about a lot of the things that it does for us. But epithelial mapping, I just don't think is particularly sensitive to identify patients for surgery in terms of screening them in or screening them out. I think it's much better utilized in determining progression or determining when people are going off of that sort of suspect curve onto maybe close to clinical. I think it's helpful when you're trying to decide about cross-linking patients. It's helpful to determine how they responded to cross-linking. But in terms of making the decision for surgery or no, we've found it not to be particularly useful in that regard.
Yeah, it is especially useful in clinic whenever you are suspicious of epithelial basal membrane dystrophy or something like that, correct?
Yeah, and I said,
Yeah.
we get it all the time, and I would never not want to have it, but not for the reason
Of screening.
for which it's been most promoted.
Yeah, and now that's another question. Now going to the Brillouin topic. Two questions came up. One of them is if you saw any differences between age, so older patients showing difference in Brillouin than younger patients.
A little, but what I will say is that yes, that data is already available. And so in our study, we tried to control age a little bit tighter so that we could compare apples to apples as it were. Yes, there is evidence that the cornea stiffens a bit over time, which again doesn't particularly surprise us. I think that's what we anticipated.
And the other question they are doing on Brillouin is if you saw, and that also everyone should read those papers. They are really elucidative. But if you saw any difference in between thinner corneas, normal thinner corneas with normal tachymetry corneas in the Brillouin.
That's a great question, and I think critically important. And the answer is no. We haven't. In either normal corneas or suspect corneas. So our suspect corneas, on average, were thinner than the normal population. But when we looked at values, Brillouin shift values within each group, there were no correlations. So it's not just a measure of corneal thickness, and it's really providing data independent from that. And we have that in 2 or 3 of the different papers that we have where we've done a formal analysis there. So
yeah, those papers are amazing. So I think we can do one last question. Fabricio, can we do one last question? How is
Yes.
Okay. Because there are lots of people you should just email us, and then I'll try to connect with Brad and
we'll get
a
response back to you.
Sure. But the last question is actually more practical. They want to know, in suspect cases of warpage, what is the conduct related to the time of no use of contact lenses? So you see those topography, then how long do you ask them to keep out of the lenses?
It's a great question. And the short answer, well, for each individual patient, the only way to determine that is to keep them out of their contacts for a while. And how long is a while? I usually try somewhere between 2 and 4 weeks as the first go around. In older types or styles of contacts tended to have a bit more impact on the findings than newer contacts. Daily disposables don't tend to cause much warpage. So I usually give them one time. I also, again, I don't know how it is in Brazil, but here if I tell somebody they need to stay out of the contacts for a month, it sounds like I asked if I can cut their left arm off. So sometimes it doesn't really matter. They're not going to do it anyway.
They will say they stayed out of the contacts, but then you see the topography is basically the same with the same epithelium.
Yeah. I will say that the number of patients that I have screened in for surgery after a long contact lens holiday is maybe 1 a year, that most of them just come back and look exactly the same. I think it's always reasonable to get a second look, but I'm underwhelmed by the impact of contact lenses on the cornea these days.
Yeah. Well, lovely. The last question was actually, when are we expecting to have the Brillouin machine available for us in our day-to-day routine? Was not me that did this question.
No, it's a good question. One I get frequently. So we're working on I guess maybe we'll call it the 3rd generation. We're setting it up now, and I'm hoping that we have a prototype in 12 months, so we'll see how that goes. But that's sort of our goal. I will say that we have more data that we're going to show at AAO. We're going to show at ESCRS in a couple of weeks. I don't know how many folks are going to get over to Copenhagen, but anyone who's coming to the academy, I'm going to present our data looking at Brillouin imaging versus basically everything out there: Scheimpflug analysis, OCT, and Corvus data. So brew on against all multimodal modalities, basically.
That would be nice. Perfect. I think we got all the first questions.
Perfect.
I'll have to email you some of them
Okay, very
later.
good.
I think we are late now.
Perfect. Well, thank you so much for the invitation, Bianca. Thank you all for hosting.
Yeah.
Okay,
Fabrizio, thank you so much. Nice to meet you tonight.
nice to meet you. Thank you, Bianca. Thank you, Random, for coming here and teaching us. It was brilliant night. Thank you.
Thank you.
Thank you so much, everyone. See you. Bye bye.
Bye bye.